So we've recently published some work which has actually been ongoing for many years, in which we've been trying to improve on the prediction of who will have a successful treatment-free remission. So if you take a number of patients who've been treated long-term with a tyrosine kinase inhibitor and sustained a deep molecular response, we know that typically somewhere around half will sustain remission if treatment is stopped, and around half will lose a major molecular response and need to restart the drug. So saying to a patient, well, you can stop your treatment, but it's more or less a coin toss whether or not you'll be successful, is somewhat unsatisfactory. So a lot of effort from a number of research groups has gone into trying to find biomarkers of the TFR outcome. So our particular area of interest has been to use highly sensitive measurable residual disease as a way of trying to improve on response prediction. So we've shown using highly sensitive DNA PCR that for the majority of people who are in a deep molecular response by conventional PCR, you can still see BCR-able DNA. But interestingly, it's not strongly associated with whether or not the leukemia comes back. So in order to try and understand this, we've done work where we sort the blood cells into granulocytes, B cells, T cells, NK cells, and monocytes, and look at whether quantifying BCR-able in individual cell fractions gives you more useful information than quantifying total BCR-able. And what was shown in this paper recently published by Ilaria Pagani, who's a postdoctoral scientist in our laboratory, was that every patient who had BCR-able in granulocytes relapsed. If you didn't have BCR-able in granulocytes, your chances of TFR were higher, but some people still relapsed. And if you looked in other cell fractions, finding BCR-able in T cells was also associated with a higher risk of relapse. And so this enables us to define three groups of patients. So granulocyte positive, everyone relapses. Granulocyte negative, but T cell positive have an intermediate relapse risk. And then those who are potentially positive in other fractions, such as B cells, but not in T cells or granulocytes, the majority of those patients sustain treatment-free remission. So this is the first time this has been demonstrated. We don't really understand why T cells are biologically important for relapse risk. It's quite obvious why granulocytes are, since it's a granulocytic leukemia. But here we have an opportunity to identify a group of patients who are destined to relapse, and so there's really limited value to those people stopping treatment. And we've also defined another group of patients who have around an 80% chance of remaining in remission, for whom continuing treatment is probably, for the majority of them, is going to be unnecessary. So I think this is clinically useful information.